Hey Cynthia, how are you doing? It's so good to talk to you again. It was so great getting to catch up and see you again at Pop a few weeks ago.
Yeah, I know. It was so fun to see you, and we got to run into all our old friends. And it's just an amazing conference because I think I always leave every year really rejuvenated and motivated and energized for the rest of the time. And it was just an amazing conversation we had with all these family physicians.
Agreed. And I think one of the main highlights for me was running into Dr. Mikah Owen and getting a conversation with him about the ACEs Aware initiative and all the things he's doing regards ACEs and how family medicine physicians can benefit from that. Lucky for our listeners, we have the recording right here. There is a special guest though. There's going to be nighttime 90s R&B Rob because I lost my voice and I still try to get that interview done. So I hope you guys appreciate it. Listen in.
I learned so much, and we're so excited to share this conversation.
All right, let's get to it.
Hey everyone, welcome to the Family Docs Podcast. We are recording live from the Family Medicine Pop Conference here in San Diego. Today, we are honored to be joined by Dr. Mikah Owen, who will be talking to us about adverse childhood experiences. Now, Dr. Owen was an advisor to the ACEs Aware initiative before joining UCAAN as a co-principal investigator. Prior to joining UCAAN, Dr. Owen was an assistant clinical professor in the Department of Pediatrics at UC Davis Health System. Real quick bio about Dr. Owen. He earned his medical degree at UCSF, completed his Pediatric Residency at UC Davis, and completed his fellowship in Community and Societal Pediatrics at University of Florida College of Medicine, Jacksonville. And just recently, he completed the Pozen-Commonwealth Fund Fellowship in Health Equity Leadership at Yale University. Welcome, Dr. Owen.
Thank you. Thanks for having me. It's cool to be here in person.
So, Dr. Owen, could you tell us a little bit more about yourself and your background?
Yeah, sure. I am a pediatrician. Clinically, I practice in a juvenile detention facility and have done a lot of work around my career on advocating for youth from marginalized backgrounds. So often youth involved in child welfare system or youth involved with the legal system in one way or another. And so across the time in my practice, I've just taken care of a lot of young people who have been really deeply impacted by ACEs and other forms of trauma. And I think my own personal journey in learning kind of what ACEs are, how they impact health, how we can support young people impacted them, led me to be really attracted to ACEs Aware and become a part of the ACEs Aware team.
This is such an important topic for us as family physicians. And for listeners who may not be familiar, can you go a little bit more in depth and explain what ACEs are?
Right. So ACEs refer to kind of 10 categories of adverse childhood experiences or 10 categories of traumatic experiences experienced before the age of 18 across 3 domains. So abuse, neglect, and household dysfunction. When we talk about ACEs, generally we're talking to those that were defined in the landmark 1998 CDC study from Kaiser Permanente and the CDC that looked at ACEs, the impact of ACEs really across the life course. And so that study showed that ACEs have a dose-response relationship with a number of poor health outcomes, social outcomes. And the data from that study has been replicated now in studies across tons of populations and hundreds of thousands of people really around the world. And that trend continues to hold that shows the dose-response relationship. So the more ACEs and individual experiences at a population level, the higher the risk for certain medical outcomes, social outcomes, poor social outcomes.
Yeah, so it seems like there's a lot of data behind the importance of ACEs and why to screen. So why is it important specifically for family medicine physicians to know about and screen for ACEs?
It's a great question. And so I think when we're screening for ACEs or for ACEs Aware, when we recommend screening for ACEs, we're recommending screening for ACEs to identify risk of toxic stress. So really anchored in that is the understanding that ACEs can lead to the toxic stress response, which is a dysregulated stress response. And it's that dysregulated stress response that can really wreak havoc on children and ultimately on people across the whole life course. So I think seeing this for me, again, I take care mostly of young people who are now involved in the legal system and have experienced a lot of trauma. So oftentimes we'll have kids or young adults now that will come to see us and have medical conditions like asthma, eczema, oftentimes diabetes, elevated blood pressure, a whole host of mental health diagnoses, increasingly, opioid use disorder, marijuana use disorder. And the kids that I've taken care of for and young adults I've taken care of in my career, we're mostly treating those symptoms one by one. So we may have topical steroids for their eczema. We may have albuterol, inhaled corticosteroids for their albuterol, whole host of psychotropic medications for mental health disorders, bute for opioid use disorder. And so we're treating all those things, but we're not really oftentimes treating the root cause. And for me, really changed my practice. One, gaining my understanding of kind of that there's a dysregulated stress response that's driving all these conditions, and increasing my ability to recognize that and respond to that. And with ACEs Aware over the last several years, we work with California Academy of Family Physicians, understanding the role of especially primary care providers in screening for risk, but also helping patients and parents and caregivers often understand the impact of ACEs, understand the impact of toxic stress. And, for me in my practice, it has been really helpful to be able to talk to parents, caregivers, adolescents, and young adults too, about the impact of ACEs and how toxic stress may be driving some of their health conditions. And had lots of conversations now with family physicians from around the state to kind of learn how they do that in their own practice, and how it could help improve that therapeutic relationship, but also improve clinical care ultimately.
Thank you so much for explaining that. I think it's so important for our listeners to recognize, and like you mentioned, how that chronic stress response can ultimately cause that dysregulation or activation in the patients that we treat, and for your population, particularly pediatrics. And I know you mentioned the link between how this can ultimately cause mental health issues that pop up, and also physical health issues that can pop up too. And I think that's something really important for doctors to recognize and be understanding and empathetic. And when we're providing that, I would say trauma-informed care through that lens. How does understanding ACEs change the way that we practice medicine? What are some specifics that you can think of that we could do in the clinic to help us?
That's a great question, and love that question. And I'm going to reflect a little bit on my practice as it's evolved over time as I answer that question. So I think for me, when I first started screening for ACEs was a couple years ago. Oh, not a couple years ago, a long time now, when I practiced in Florida. And I was seeing a lot of kids who were coming home from security detention, a lot of kids who were on really high doses of psychotropic medication. And, we were doing a lot of intake. And so at that time, I was screening for ACEs, understanding their impact, understanding their prevalence, but I was really just using it as a way to really communicate with the young people and with the families. And what I kind of noticed in my initial practice was the young people that I took care of, they carried like a lot of guilt often. They had lots of feelings of anger, lots of feelings of anxiety. They had this feeling of wanting to do better, but often felt like overwhelmed or they couldn't, and really felt guilty oftentimes when they were coming home that they were letting their family down. So I started screening for ACEs as a way to communicate with them and help it to educate them really about the impact of adverse childhood experiences and trauma, and about the changes in like brain development, brain architecture and physiology. And that in and of itself, for many of my patients, was such an eye-opening conversation for me. So taking care of kids that were often coming home from several years of detention and talking to them about trauma and its impact, and seeing them like break down crying and say, "Oh man, this makes a lot of sense to me," or the sense of relief that it gave them of like, this isn't my fault. So, I say that to say that for me in my practice, especially initially, that screening for ACEs and educating about the impact of trauma, like really improved the therapeutic relationship that I had with many of my patients and helped me to create a better connection. And that was really meaningful to my practice. But at that time, I hadn't really connected as much ACE screening and like the impact of toxic stress and evidence-based strategies to mitigate the toxic stress response. And so I think that is what a lot of what we do with ACEs Aware, and that's what a lot of the biggest change over the last, I would say, 5 or 6 years in my practice is kind of understanding that I'm screening for ACEs to understand the risk of toxic stress. And when we have a patient that's high risk of toxic stress and may have let's take a patient with asthma that's high risk of toxic stress and they have asthma. I'm still going to treat the asthma in the same way that I would based on the guidelines. But in addition to that, I'm going to try to add to my clinical care evidence-based strategies that mitigate toxic stress. So often that can look like, hey, have you tried meditation? Well, one, do you understand, let's have a conversation about the impact of ACEs and what toxic stress is. And here are some evidence-based interventions that you can try to address the toxic stress physiology. That can be physical activity, good nutrition, be mindfulness, meditation, several things that can be done. So that's one thing that we can do to really change our clinical practice is to implement these evidence-based strategies. But also in California, there's a lot of additional resources that are available, especially to young people. And so really connecting that ACE screening with those resources that are available, things like Saluna, Bright Life Kids, so behavioral health coaching apps that are available free in California, CalMap, and the psychiatric consultation lines, enhanced care management, community health workers, doulas, lots of resources that are available here in California through Medi-Cal that could be linked to the response for ACE screening.
Yeah, and thank you so much for touching on the fact that I wanted to highlight was what you said, connection and building that relationship with your patients as the foundation of really mitigating that dysregulation activation resulting from that chronic toxic stress. And what a powerful way to affect behavioral change, going from, I heard you say, emotions of guilt, anger, anxiety, and moving that into relief for your patients. That can be incredibly impactful and powerful. And for those of you who do want to learn more about adverse childhood experiences and trauma-informed, resilience-oriented healthcare, CAAFP has an excellent resource through our website at www.familydocs.org/ACEs. You can also get more information at livebeyond.ca.org. And the rest of the information mentioned will be in our show notes as well.
Thank you, Dr. Owen. I think what you just spoke upon and what Cynthia attributed to, excuse me, is that connection. I really never looked at ACEs screening as a way to communicate with the patients. And I think that was really powerful just for me right now. Something clicked in my head and I'm like, wow, moving forward in my practice, I perform ACEs screening as a form of screening. And obviously I know about toxic stress and trying to move the needle forward, but like using that as a way to communicate with not just the patient, right, but their family and their whole team. Like we just had a talk earlier this morning talking about we're a team with the patient, and sometimes all these different uncertainties that we don't know about medicine and how we go through it, but sitting with the patient, sitting with the family, letting them know that we're part of that team, and using this as another tool to communicate was actually something I had never really thought about, and I think is really powerful for our listeners to be able to kind of use that in their own practice. And on the note of knowing about toxic stress and knowing about ACEs, we see that what you're alluding to is that trying to get this early intervention and all these different types of interventions and how that may potentially affect long-term health outcomes. Like, do you know of any, like what specific long-term outcomes this early intervention does affect, or have you seen the effects of it in the future? Because a lot of times I could do ACEs screening now, I never follow the patient after that. But do you have any specific information for our listeners to know that how does this early intervention actually affect their long-term health outcomes?
It's another great question. And there is a lot of work being done specifically around ACE screening and response here in California to look at the impact over time of a lot of the work that we're doing here. I think there's a lot of examples that come from, at least for ACEs Aware, from like the Los Angeles area. And so we've seen clinics that have done things like combine ACE screening in patients with high risk of toxic stress with community health workers. And they looked at that, and what they saw is that the time to service, and service meant a lot of different things for the patients in that population. For some, it could be like the timeline to having an IEP evaluation, or the timeline to improvement in symptoms as defined by the patient or family. And we saw a really significant decrease in how long it took for patients and families to have that service provided. Another one that really I think sticks out to me was done in LA, where they combined ACE screening and kind of depression and anxiety screening. And for those with high ACEs and either depression or anxiety, referred them to a virtual-based mindfulness program, right? Again, mindfulness being an evidence-based strategy to mitigate toxic stress, and saw significant improvements several months after that intervention in the reporting of the symptoms of both depression and anxiety. And then kind of outside of the ACEs literature, I think of course in pediatrics, there's a ton of literature that just talks about early intervention in general, and how impactful early intervention can be in preventing downstream outcomes, but also saving a lot of healthcare dollars. And so I think that's one of the big connections that we're focused on in ACEs Aware too, is that, ACE screening, especially in children, is an opportunity to identify risk before the outcomes develop. And once we can identify that risk, again, here in California, a positive ACE screen really opens the door to a whole host of benefits and services that we can connect children to in hopes of preventing those downstream outcomes.
Yeah, thank you so much for sharing that. And I think you mentioned a couple of things that physicians can do after they do identify a positive screen. And when you're looking at, I would say most physicians are employed, and you're seeing patients every 15, 20 minutes, and screening becomes very part of your protocol. And so in your opinion, what can physicians realistically do? Because they are back-to-back seeing patients. What can they realistically do when they do identify a positive screen in their patients?
Right. So I think in first pointing out that there are a couple studies and evaluation done by RAND here in California that shows that ACE screening can be done in a way that doesn't add a very significant amount of time to a patient visit, oftentimes less than 5 minutes. And I think the other thing in my practice that I've learned, and I think the literature bears out and others are saying as well, is that if you have a patient that's really impacted by ACEs and toxic stress, and that toxic stress is unrecognized either by you as the clinical team or by the patient, caregiver especially, that it is very likely that you're going to be having ACE-associated health conditions that are negatively impacted by that toxic stress physiology. And you're spending a lot of time treating that problem, but not necessarily getting to the root cause. And so I think that it really does kind of improve the ability to handle some of these chronic conditions that we're often seeing, especially when it's linked to toxic stress physiology. And again, I think that for me in the clinical setting, the thing that the clinician and the clinical team can do is really supplementing their usual care with the addition of evidence-based strategies to mitigate the toxic stress response. And we have a lot of resources on our website, acesaware.org, and our training site, training.acesaware.org. With some resources, we have like a treatment planning tool where clinicians and clinical teams can kind of create a plan with the patient or with the caregiver to say, hey, these are some of the evidence-based strategies that have been shown to mitigate toxic stress. Which of these do you think that you can implement within your life? Is it nutrition? Is it changing how we eat? Is it physical activity? Is it mindfulness? Is it focusing on strengthening our relationships that we have in our life? And then let's get specific. What does this plan look like? How are we going to be able to implement that? And then let's come back in, a month or 2 or 3 to see how this is going. So there's some resources on our website. We also have like a very long but amazing provider training course on stress busters. And so it's modular. So you can go, stress busters are the evidence-based strategies to mitigate toxic stress. So you can go and spend some time on each of those modules, and it talks about what those are and how you can implement those in your clinical practice.
That sounds like an amazing resource for our physicians. And I really like the fact that you pointed out we want to address the root cause potentially of all of these medical problems. And if we took a moment to just do that, that it might actually improve this patient's care, decrease the medications that they're on, spending time addressing these medical problems if we just, again, took that moment to address the root cause. And I love that you pointed out that the collaborative effort too with the patients and eliciting their feedback on what's actually feasible for them, because I think that's really important. We do also want the listeners to know that CAFP is proudly reaccrediting the updated Becoming ACEs Aware core training. And you can potentially take that training if you're interested at training.acesaware.org/AA.
All right. So, in the interest of the first lecture we had again today about storytelling, a lot of our listeners, sometimes when you make it more personal, then people are like, oh yeah, like it touches them a different way. So I really want to ask you, I know we're talking about how it changed your practice in regarding to ACEs screening, but do you have any specific patient examples of how this ACEs screening changed your patient care or their outcome down the line? It could just be one example. You don't have to go through a bunch of them, but we just want to know like how in your clinical practice this ACEs screening has affected a patient.
Yeah, I think a lot of examples. And I think when I first started screening for ACEs, again, I'm taking care of that time, young adolescents and young adults that are coming home from being incarcerated for several years. And that was in Florida at the time. And oftentimes those young adults are coming to us on really high doses of psychiatric medication, often risperidone, Seroquel, very common for young people who have been involved in the legal system, especially 5 to 10 years ago and beyond that. And so, as part of my intake, when those young people came home, it was screening for ACEs and talking about the impact of trauma and tying many of the symptoms that they were having and they were experiencing to the literature around trauma and educating them about that. And so I think for me in that practice, and this practice often continues though in a little bit of a different way since I'm in California, not Florida now, but we were able to, through conversation, through consultation, through working together with those patients and families, get many of them decrease their psychotropic doses significantly, and for many of them, get them off medications. Very often for me in my practice back then is what we were seeing after talking to many of our patients were pretty classic trauma responses, internalizing and externalizing behaviors. And we're able for some to get them off some of those medications and for some to get the doses down or change them to a medication profile with less side effects. I think in my practice today, we have a fair amount of adolescents and young adults that we treat for opioid use disorder. And I think in treating them, with medication management and with BUP, and again, I think supplementing that usual care, right? So for me, we have our kids with opioid use disorder, we're treating them with BUP. That's kind of our standard care, but then that kind of ACE screening and toxic stress physiology response, really building that connection with them, talking with them about the impact of ACEs and toxic stress, making that connection with them. And almost universally for those young adults and adolescents that I take care of, there is a lot of trauma, and those conversations really resonate with them. So then it's about getting them connected to their resources. So things like, Live Beyond and some of the educational materials that they have, whether it's like community health worker services, ECM, or helping them learn about like mindfulness and meditation and how they can implement that in their practice. And so for many of those young people, I think we've seen really positive outcomes in the sense of they're continuing to engage in their treatment in the facility and outside the facility, continuing to take the medication. And so I think lots of positive outcomes in that regard, but also don't want to paint the picture that that's everyone, right? Or that's every experience that we have. The impact of ACEs and toxic stress and trauma can be really pervasive. And a lot of young people, a lot of adults, a lot of families don't have the supports or the connections or the relationships that they need to heal from ACEs and toxic stress. So I think here, and again, that's one of the reasons why I'm super happy to be a part of the ACEs Aware team, because it's about identifying what can we do in healthcare and in a scalable way to increase those buffering supports within our communities.
The work you've been doing is just very incredible. And I'm just so curious, what initially inspired you to go on this journey and do this work?
I knew I wanted to be a pediatrician, and I also knew that I wanted to work with youth that were involved in the legal system. Super passionate about developmentally appropriate, trauma-informed reforms to our youth legal system, and have done a lot of work in that. And as I really before residency, but in residency and in my practice, really looked at what are some of the root causes that cause a young person to be involved in the legal system or become at risk for involvement in the youth legal system, and just seeing in all that literature the pervasiveness of childhood trauma in their lives. And then in my practice as well, as I kind of built a practice that was focused on taking care of kids from marginalized backgrounds, just the almost universal presence of ACEs and other forms of trauma made me really want to learn more about how I can improve my own clinical practice. And I would say leaving residency that I felt like we weren't trained well enough to understand the impact of trauma, to understand how to respond to it. And so just started to read really everything that I could about the impact of ACEs and trauma, and about what are some of the evidence-based interventions, how we can support young people that were impacted by ACEs. And I think from a relatively early part of my career in my practice, trying to implement some of that and seeing that, this really is making a difference and it's making my practice better. I'm having different types of conversations with teenagers, with caregivers. There's a different type of connection. Some of the recommendations that I'm making, like before, was like, we're not able to do that. That I was just seeing a lot of progress in my practice. And I think that made me really want to double down and get better and better at it and learn more about what that looks like. And, again, thinking about, well, how do we take this to scale in primary care, especially?
Wow. Thank you so much, Dr. Owen, for such an insightful conversation. I think this has been one of the more insightful conversations that I've had with people, and our listeners are definitely in for a treat when they listen to this podcast. But we might have to have you on again, because I think there's so much information that you have. There's so much knowledge that you have to share. And I think even this brief interview today, you showed us so much. And I'm already inspired and ready to start rolling with ACEs, tomorrow. But, for our listeners who are out there, and like, what are words of advice, I would say, do you have for a family physician who's eager and hungry and ready to start ACEs Aware and ACEs informed care tomorrow in their practice? I mean, today is Saturday, so maybe Monday. Monday in their practice. Like, what advice do you have for them to be able to push this forward? Because it seems like you're so passionate about this work, and you're obviously trying to scale this work. And as family physicians and in primary care, we want to continue that work. So what piece of advice can you give our listeners right now to be able to start this work as soon as the weekend is over?
A couple things. So I think one is oftentimes clinicians may be hesitant to screen for ACEs or think about toxic stress because they feel like they don't have the resources, or their community doesn't have the resources in place to support those who are impacted by ACEs, or that question of what do we do next. And so one, just reinforcing that in my practice and for many people that we talk to, is that ACE screening, when done in a trauma-informed way, can really help build a therapeutic alliance with the patient, with the family. But also that there are, evidence-based interventions. And again, really focusing on, there is an opportunity for clinical teams to supplement their usual care with these evidence-based strategies. So there is something that you can do. Even if there's not the best resources in your community, or there's barriers to accessing those resources for the families in your community, that there are things that you can do to supplement your clinical practice to help support, whether it's children, adolescents, young adults, adults, in mitigating the toxic stress response. And I'm really just excited with how you framed the question, right? That people are really excited to get going. But also, I think a word for people who may be a bit more hesitant. I think there's a lot of evidence now that shows that screening for ACEs is acceptable to the patients. There's lots of literature out there that suggests patients agree that we should be asking these type of questions. There's studies out there that show that clinical teams, clinicians think that this is feasible and doesn't add a lot of time to their practice. And so for some of us, these may be hard questions to grapple with, or we may not be used to kind of incorporating them into our visit. But, whether we ask about them or not, we know that our patients are impacted by ACEs and toxic stress, and they're going to continue to be impacted by toxic stress physiology. And so I think asking these questions and having these responses built into our practice can really improve outcomes across the state.
Yeah. And I think I wanted to emphasize something you had mentioned earlier, because sometimes physicians who maybe aren't doing this regularly, there is some trepidation to starting screening. You mentioned and gave us a whole host of resources that we will have available in our show notes. And I think an important thing to remember is that for our listeners and physicians is that you don't have to do everything at one time, at one visit. You mentioned before in your clinical practice, it sounds like you see the patient, you screen, you maybe have a brief conversation, and you said you follow up afterwards. And it's that consistent follow-up that builds that longitudinal relationship that also makes a huge impact for the patient too.
So I just learned so much about the engagements that we've had with clinicians through CAAFP, through either some of the TIROH groups or the conferences, and some of the things that kind of have stuck out is, we were talking with one clinician about implementing stress busters and what that looks like for, my practice and what that looks like for different practices. And he was talking about how, well, the lead time, the timeline for a follow-up visit for us is often 3 to 4 months out. And it's like, wow, man, that is a lot different. Like, how do you implement stress busters in that way where for me in my practice, I was used to seeing somebody for follow-up oftentimes, every 4 weeks for several months at a time while we're working on things for pediatricians. And then also talking here at this conference and learning more about family physicians and the power of those, where the same clinical team is taking care of both the child and the caregiver and other people in the family often too, right? Just the ability to build that connection and talk to them about the impact of ACEs and toxic stress just has so much power to, change life course trajectory, and having someone, a parent or even a grandparent, understand the impact of ACEs and toxic stress in a way where they're hearing it from somebody who they actually have a connection with, who they actually trust, and how that knowledge can translate through generations and really, kind of stop the transmission of toxic stress physiology, or that intergenerational transmission. I think the power of that is amazing. And so I love coming to this conference because we get to hear how, family practice is unique in terms of my experience in care, and all the ways in which family physicians have implemented ACE screening in response, the barriers that they have encountered, the innovative strategies that they've implemented to overcome those barriers. I've learned a ton from being here, and hope that we continue to get to come and engage with family physicians and learn how they're doing this work.
I got chills just listening to you talk about that. And you said the generational impact. I mean, this is creating real lasting change, cultural change, generational change. Yeah, that was incredible.
Yeah. Like I said, it's amazing that you came all the way to our family medicine conference, right? Just, to do this ACEs talk and do this ACEs work. So obviously it's very important to you, but to us, you're a pseudo family physician. I mean, you're doing very the same exact work. I always tell all my medical students that rotate, they say they're like pediatrics or OB. I'm like, you're going to be a family physician, but I think it's okay for you to be a pediatrician. But in our family, you can always come to these conferences. You're always welcome to come to POP or AMAM and all of the above. So we appreciate everything that you do.
That's awesome. Thank you.
Thank you so much for this amazingly, incredibly insightful conversation. We really, really appreciate it. And I think you've given us so much to think about and our listeners to think about too. So thank you so much for joining us today.
Awesome. Thanks for having me.
Thank you.
Don't forget to subscribe, rate, and share the Family Docs podcast. Come back for more discussions on pivotal topics in the medical field. Thank you for tuning in. And until next time, this is your favorite family physician.
And your other favorite family physician,
Dr. Rob Assibey.
And Dr. Cynthia Chen-Joea. This podcast was created, produced, and recorded by the California Academy of Family Physicians. The views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent or the California Academy of Family Physicians.
Hey, this is Dr. Rob Assibey with the 1990s jazz. All you night owls out there, we got some hits for you tonight.